Okay, today I'm Christina Traber, and I'm a geriatric nurse practitioner with the SLU group. And today we'll be talking about wound care management, specifically in the older adult population. And a disclosure that this project is supported by the Health Resources and Services Administration GWEP grant. And I have no financial disclosures and no off-label discussions today. So today specifically, we will be talking about aging changes in the skin, types of chronic wounds, and then each of those, their etiology, the characteristics, some treatment choices, and also dressings. So skin changes related to aging overall. We know that the skin overall will become thinner and more fragile. Also, we have reduced dermal vascularity. We have less collagen, less adhesion between the skin layers, redistribution of fat, a decrease overall in sensation, like in neuropathy, and decrease in sweat production. And all of these make older people more prone to having skin tears, wounds, and skin changes. So now for chronic wound management. So overall, what is a chronic wound? So a chronic wound is a wound that fails to proceed through an orderly and timely process to produce anatomical or functional integrity. So basically, there are four main stages of wound healing. So if you fell and you scraped your knee and you got an abrasion, you would first start with stage one, which is homeostasis or coagulation. So you would have clotting and vasoconstriction at that site, so the bleeding would stop to that knee abrasion. And then stage two is this inflammation stage. And in that stage, you have cytokines and growth factors are released. You have vasodilation. You have phagocytosis, where white blood cells come in and engulf that bacteria or any debris that's in the wound bed to get rid of it. And this stage lasts anywhere from 1 to 25 days, depending on kind of how big the wound is. Stage three is the proliferation stage. So this is the stage that actually healing will actually take place and closure. So you have collagens, you have granulation, you have new epithelial cells, so kind of the silver gray cells that kind of are the first layer to resurface that wound. And eventually you'll have complete closure of that wound. And then stage four is kind of after it's already closed, maturation, where that scar tissue is formed and you get thicker skin on top. Of note, your scar strength after healing is still only about 80% of what it was prior. So people that have had an ulcer, that's important because, like I said, it's 80%, not only 80% is strong, therefore might be more prone to opening. So that's kind of the normal stages of how something should heal. So if you had a knee abrasion, you would go through these things, you would get a scar, it would heal. A chronic wound tends to be a wound that's open for more than 3 months, so a longer time period, and then it gets stalled in the stage two. So stage two, this inflammatory stage process, the wound gets stuck there. And so all of our treatments are kind of based on trying to decrease that inflammation and to create a better wound environment so that the wound healing can continue. So there's excess inflammation, and that creates a hostile wound environment. And therefore, there's also a greater risk of infection overall. So in chronic wounds, we know that overall the incidence of chronic wounds is increasing among older adults. This is a big impact on both individual quality of life and also institutional, which we'll talk a little bit about. So for example, it's estimated that about 1 to 3% of healthcare expenses in developed countries go to complex wound management. So to your supplies and to wound nurses and to all of those things, 1 to 3% of healthcare expenses. And that equates to about $25 billion a year in the United States alone. So big cost institutionally. And then, of course, individually, having a wound affects people's quality of life. It often will equate to a hospital visit, a hospitalization, and then sometimes even placement into a nursing home or long-term care facility. So typically, there's lots of types of chronic wounds, but the kind of four most common that we're going to spend a little bit more time on today are pressure injuries, diabetic ulcers, vascular or arterial ulcers, and venous stasis ulcers. And these are the ones you'll see most commonly in the long-term care setting. So starting with pressure ulcers or pressure injuries, a pressure injury is a visible evidence of pathological changes in the blood supply to dermal tissues. Its chief cause we know is related to unrelieved pressure. It affects only about 0.5% of the whole population, but this equates to about 70% of ulcers for occur in geriatric population. So obviously a big impact on geriatrics. 95% of pressure ulcers typically occur in the lower body, more specifically on the sacrum or coccyx, and then about another third on heels. And we'll talk a little bit more about that. So what kind of impact does this have? We talked a little bit about cost, but we're going to go a little bit more into that. So in the United States, about 2.5 million patients per year develop a pressure injury. And with that, the National Pressure Ulcer Advisory Panel estimates that an annual cost to the healthcare system is about 3.6 billion. Hospital incidence or a frequency of new cases is about 12% a year. Community prevalence, so that would include both the new and existing cases out in the community, can be as high as about almost 30%. And globally, this is found to be around 12%. Other studies found long-term care prevalence to be between 12 to 50%, depending on what home. So still kind of falling into those categories. So we just said that about 70% of these ulcers occur in geriatrics, but who specifically is more at risk? And so we're going to talk a little bit about trying to figure out who is at more risk for skin concerns than others. So those patients that have comorbid conditions like diabetes, vascular issues, anything that would cause more immobility are more at risk. Anyone who obviously has paralysis is more at risk. Anyone who has reduced tissue perfusion, so someone that has lung disease or cardiac issues can be more at risk for having ulcers as well, especially for vascular problems. People that are frail are more at risk. So I'm sure you've heard, but I'm going to repeat the St. Louis University Rapid Geriatric Assessment. And part of that is the frail screening tool, and that's looking at frailty. And we know that people that are frail who have had issues with mobility and also loss of weight are more prone to having skin conditions. And then there's a category just to mention of device-related pressure ulcers. So people that need respiratory masks or have NG tubes or drains. Those people that have condom catheters. I had a patient who had a condom catheter on for incontinence, and he unfortunately had dementia and could not verbalize anything to his caregivers. And the condom catheter was too tight, and he actually developed gangrene on his penis. So just all of those kinds of things, looking at all of those and how they interact are important. So again, those that have poorly controlled systemic disease are more prone to having skin problems. Diabetes, neuropathies, we said, because people can't feel things. They don't know when they're having discomfort that might be creating a wound necessarily. We know that their skin is more fragile. Those that are cognitively impaired that can't tell us when things are hurting, like we just discussed. Also, people that have had any kind of hardware or foreign body or radiation therapy are more prone to have skin concerns in those same areas. People that don't have good nutrition or, again, who are frail are more prone to having skin issues. And to go back one slide to, I don't have it on here, but the snack is this other lower portion here, and that's the nutrition assessment. And so that's looking at appetite and how the food tastes and how good they are at eating. And a score of less than 14 would indicate that they are at risk for having issues. Anyone also with malabsorptive syndrome, so Crohn's disease or something like that, that just doesn't have good nutrition, would be more at risk. And then medications. So people that are on obviously cytotoxic cancer drugs, anyone on an immunosuppressant or a steroid long term, vasoconstrictors, anticoagulants cause more bleeding. So if they have a wound, that would be a problem. And then NSAIDs cause more inflammation issues as well with wound healing. So they kind of get stuck more in those inflammatory marker areas. So looking at a med list and doing a good review is important when we're looking at someone who has a wound. Just to talk briefly on pressure injury staging. So when someone has a pressure ulcer, it is staged according to kind of what level of skin is affected. So stage one, the skin is not broken, but it has that non-blanchable redness. So it has some injury because you can see the redness. However, it's not opened yet. And the idea is hopefully if you could find something in the stage one, potentially if you could relieve the pressure, it may not open. Stage two is that top layer of the dermis is open. Stage three, that ulcer is going to extend into the subcutaneous fat. And stage four is when it's going to extend into the muscle or bone, and there might be more likely to have undermining or tunneling surrounding it. So in order to do staging, we have to be able to see the depth of the wound because that's what we're looking at. So if anything has slough or eschar in the wound bed, we would not be able to stage it because we could not confirm how deep it is. So that would be considered unstageable. So for this wound you see, you really can't tell how deep it goes into at the surface because you can't see down into it. So this would be considered an unstageable pressure injury due to the dark eschar. Also, sometimes you'll get kind of a dark purple discoloration, not the non-blanchable redness, but a purple, almost like a bruise. Sometimes the bruised kind of color indicates that there's been a pressure injury or a DTI that's deep. And again, by trying to quickly get that pressure off, we can hopefully relieve it from turning into something more severe. Of note, there's some limitations to this pressure staging. Again, we're only staging pressure ulcers. So we're not staging any other kind of ulcer. We're not staging diabetic or vascular ulcers. With that, these ulcers do not progress from 1 to 4. We know that an ulcer can show up and it can be open up as a 2, 3, or 4. So it doesn't have to go from 1 to a 2 to a 3 to a 4. And in that way, also, healing does not happen that way. We went through the stages of healing. Again, with a chronic wound, it kind of has a mind of its own. So if you have a stage 4, we would never reverse stage it. So for example, if you have a stage 4 and it's healing, it will always be a healing stage 4. It would not be a stage 4 and now a stage 3 and now a stage 2 because there's no way for us to really do that accurately, if that makes sense. And again, the staging process is inaccurate unless all that eschar or slough is removed so that we can adequately see the wound bed. So overall, pressure treatment general guidelines kind of fall into kind of 4 main ideas. First one is obviously to relieve pain because pressure ulcers often come with pain because you have an open wound. But the real mainstay of treatment obviously is to relieve that pressure because that's where it came from. And we'll talk about all the ways to do that. The third kind of treatment guideline is that all wounds have to be moist to heal. So all of kind of when I'm out doing wound rounds is based on how moist the wound is. If it's too dry, adding moisture. If it's too wet, taking away moisture. So again, it's kind of finding that sweet spot of moisture. And we'll talk about different ways to do that as well. And then the fourth treatment guideline is you have to remove all the necrotic debris. So if something has eschar or slough inside, that has to be removed so that healthy tissue can then fill in. And again, multiple ways to remove it. And we'll talk about that in a minute as well. So pressure relief comes in many forms, mostly in DME. So we know that there's lots of different kinds of beds that taunt themselves as being pressure relief. Kind of the mainstay of a really good pressure relief mattress would be the air pressure, alternating air pressure mattress, which most places have. If needed, they will rent or buy mattresses. The facility will to be used in those circumstances. A lot of the ICU beds in hospitals will say that they are low air loss or pressure relief mattresses. So there's lots of different levels of that, but kind of the mainstay, like I said, is this air alternating air mattress. There's even one step above that, which is considered, which is like an air fluidized bed, which is even less pressure. It was kind of the Cadillac of all the beds. So someone who is immobile and can't move and needs pressure relief will often get an air mattress. Cushions. So if they're going to be in a wheelchair and they have a wound, they need either a gel or a foam or a Rojo cushion. Rojo cushions are kind of the gold standard. Unfortunately, they're difficult to get covered a lot of times by insurance. They typically want you to have at least a stage 3 ulcer to get covered. So again, trying to jump through those hoops to get that done. But there's some good gel and foam that also will work for pressure relief. And then if you have someone who's going to dialysis, then that foam or that mattress, that pressure relief cushion also should be moved out of their wheelchair and put into their dialysis chair while they're sitting there, because they're sitting there for about 4 hours. There's pillows that we use for wedges for positioning, and then boots. So if someone has a heel ulcer, even if they're on an air mattress, because of the way your heel sits on that bed, bony prominence, they still need to have a boot on. And the gold standard for a heel device is either the Leonard or the multi-POTUS. And so all of the things with pressure relief is that everyone should be being moved every 2 hours. So they should not be in any position, even with a cushion, for more than 2 hours. So as a CNA, the most important thing is to make sure that those patients that cannot be being moved are getting moved every 2 hours. And then also that all of the equipment we just talked about, if they're supposed to have it, that's actually in place. Coming in to see a patient for wound rounds, for me is so disappointing when I come in and the boots that are supposed to be on their heels are in their wheelchair at bedside, because, obviously they're not doing any good. So as a CNA, just to kind of really champion making sure that all of their correct equipment is on and that they're getting that good turning every 2 hours, anyone that can't turn themselves. So to go back to the moisture component. So like I said, wounds have to be moist. So if you kind of look at this chart, anything that's low exudate would be considered a drier wound. So if it's a drier wound and it doesn't have a whole lot of moisture, we would probably be adding some kind of hydrogel or something that would give it some more moisture, right? All the way up to the other end of the spectrum where we have something that's really putting a lot of drainage, we're going to have to find something that can control some of that drainage, because a wound that's too wet or too macerated also will not heal. So that's when we use things like alginates, which are a derivative of a seaweed that kind of you put in the wound bed and they fluff up and they absorb that moisture off the wound bed, all the way to a foam dressing that will absorb some of that moisture. So it really helps to keep that wound bed kind of at its best, being moist, but not too dry or too wet. And then the thing I would mention for those of you that are working bedside is, again, because these patients are often incontinent and have other things going on, sometimes the dressings do come off during pericare and during therapy and have to have a shower or whatever. Dressings only work for wounds when they are in place. So if you are a CNA and you are doing pericare and the dressing comes off, that's okay. We just need to let the nurse know so that she can replace it. Or if you're doing pericare, you notice there's not a dressing on something that you were told in a report there is supposed to be a dressing on, please let the nurse know. Because again, having things in place that are at bedside or not on aren't helping us or the patient. So just briefly, because I talked about so if you have necrotic debris that's in a wound, that good tissue cannot fill in. And so the idea is that we have to do some kind of a debridement. Most of the time when you say debridement, everyone always goes to the scalpel. Debridement means that someone's cutting something. What's interesting is that in all the studies that have been done about debridement, no study has actually been shown that debridement actually accelerates wound healing better than any other kind of debridement. So for example, if I'm doing a debridement on a wound at the long-term care facility, I could use an enzyme like Santal, which is a medicine that's going to debride something, or I could take a scalpel in and do a bedside debridement. But overall, neither one of those methods are better than the other. That bad tissue needs to come out some way or another to heal. However, which method you're using doesn't really matter. So based on that, I tend to use more conservative measures for debridement overall. Sometimes it does require a surgical. It just kind of depends on the eschar and the type and how thick it is. So surgical debridement is using some kind of surgical instrument. So either a scalpel, a curette, scissors, forceps, something that I'm going to actually remove tissue. It's considered the most aggressive type of debridement. Like I said, I can do it bedside at the nursing home. It can also be done surgically in the OR for bigger wounds that might need that. There is a pain component I am cutting. However, if the wound bed, the tissue that you're removing is dead, typically there's no sensors there. So typically they would not feel it. I typically use surgical debridement for things that have very thick, hard eschar that I can't get an enzyme or a treatment dressing to get through that thickness, that permeability is not there. And so I will sometimes even take a scalpel and kind of make hash marks in it so that I can get that medication into the wound. And so that would be considered an autolytic debridement. So autolytic debridement is often considered the most slow method. However, it's like probably the most commonly used debridement kind in long-term care setting. And it's most commonly used because there's typically no pain. And this method is using the body's own enzymes and moisture beneath the dressing. So again, maintaining a balance in moisture is important. And so commonly you would use a hydrogel, something that's going to loosen up that tissue that you want to come out more slowly. And it does work, but again, sometimes it's a little bit slower than some of the other ways. Enzymatic, like I said, would be something that is a topical agent, and chemically it kind of liquefies that necrotic tissue. And the medication that most often people know of is called Santal. And so that is something that the enzymes will actually dissolve, and engulf that tissue within the wound matrix and kind of pull it out. It can be expensive. Santal can be expensive depending on how big the wound is, how much Santal you need to do it, and that kind of thing. And it kind of depends on your insurance. But again, it is commonly used in long-term care setting again because it tends to have no pain associated with it. The nurses could do it at bedside. It does have to be moist to activate. So if you have a dry wound bed, sometimes you have to put some moistened gauze on top of that Santal to get it to start working. And the other thing is you use it for the period of time that you need the debridement to happen. So it's not enzyme specific to bad tissue. So it's eating away at tissue overall. And so once you have the majority of that wound debrided, you would stop the Santal treatment at that point. Mechanical debridement is often by irrigation or like hydrotherapy. In the nursing home, we sometimes use physical therapy. We'll perform closed pulse irrigation or CPI. And it's a form of kind of pulse lavage with suction. So they use this pressurized pulsed solution to irrigate and debride the wound of necrotic tissue. It's typically well tolerated with minimal discomfort. It is usually cost effective. The other thing to try sometimes, a lot of surgeons like wet and dry dressings with that idea is that the wet dressing is put on as it dries, it holds onto that necrotic tissue. And when you go to change it and take it out, it kind of pulls on that tissue, on that bad tissue and takes it out. So could also be done in that way. Biologically, haven't seen it at the nursing home, can't say that I've seen it very often, but there is use of maggots and flies and stuff like that that are used to digest those dead tissues and pathogens. So that's also an option. But again, long-term care setting wise, typically you would see kind of those first 3 at the bedside, and then sometimes physical therapy, like I said, would do the closed pulse irrigation. So Infection is a big thing with pressure ulcers. So the big thing to know, I think, on this is that all wounds are colonized. If I, took a swab and swabbed my skin, I would grow all sorts of wonderful things on it. Bacteria is all around us. So we're really trying to decide what is actual colonized and what is actually a true acute infection is important. Clinical diagnosis for infection is based on these symptoms. So the wound has to have erythema, edema, oftentimes it'll be warm. Sometimes there will be an odor, purulent drainage, and crepitance. So the thing with odor, which is interesting, is that if you have a dressing and you take it off a wound, most likely that dressing does not smell great. It's been on a wound for a day, 2 days sometimes, if it's a every other day dressing change. And so I like to tell people that it would be like wearing a pair of socks for 2 days. That probably those socks don't smell great. It doesn't mean that your feet are infected, though. It's just the dressing. So, in order to know if something truly has an odor, I like to take off the dressing, clean everything nice, and then look at the wound, smell the wound, see what the wound itself looks like, not the dressing. So, again, just being kind of vigilant about understanding the signs and symptoms. And then really to get an actual diagnosis of wound infection. Again, we're not just running around swabbing wounds because again, they're going to grow stuff. So if we're really worried about wounds, getting scans for osteomyelitis and actually doing tissue biopsies for infection. So those are kind of pressure ulcers in in whole. So now we're going to move on to diabetic ulcers. So diabetic ulcers are multifaceted. They typically come along with diabetes, obviously, with neuropathies, with foot deformities. They typically are from sites of pressure or shear, callus formation, that kind of thing. So about 35% of diabetics have neuropathy. Up to about another 8% or so will develop a specific foot deformity that's kind of the rocker bottom, and it's called Charcot foot. So that's something to be aware of. And because of these deformities and these decreases in sensation, they are more prone to having shear and calluses, and these equate to wounds. So incidence of this is about 2 to 5% of diabetics annually. They are difficult to heal, and the reason is because they tend to reoccur. Locations below the ankle, they have kind of those even round margins, and they have this nice peri-wound callus that gets built up. So kind of stereotypical diabetic ulcers. The key to diabetic ulcers is to offload the pressure. So whatever is rubbing or causing the callus, we want to get rid of. I look in people's shoes because you would be amazed that if you look in someone's shoes on their insert or sometimes on like the top of their hammer toe, you can see on the shoe where it's rubbing. I've been known to cut people's shoes, cut holes in the top of their shoes, cut holes in the inserts in the bottom of their shoes to offload pressure. Good orthotics are really important. So I send people a lot of time to get to podiatry to get good orthotics as well. So pressure reduction, either with diabetic shoes, with foam inserts. Sometimes we have to put people in kind of offloading walking casts to get that pressure off. Obviously, blood sugar control is really important because that blood sugar control helps with healing. And then we're going to optimize the wound environment. So again, we want to make sure that the wound environment is moist. And sometimes it depends on using any and all of these choices. Vascular and arterial ulcers. So a lot of times you'll have some kind of overlap. So diabetics will have vascular disease. Some vascular, patients will also have be diabetic. So it kind of correlates back and forth. About 8 to 12 million adults have vascular disease, but only about 10 to 30% of them have that kind of classic claudication. So pain with walking, pain in their legs. So sometimes they don't always know that they have it. Other symptoms of vascular disease include absence of hair, absence of pulse, cool temperature, pain with elevation. So because they don't have good blood flow, when they elevate their legs, it's more painful than when they hang their legs down to gravity because that helps the blood flow get to their feet. Typical areas of the leg and feet where they get the vascular ulcers tend to be the distal part of the leg, the ankle, and the dorsum part of your feet and toes. You can have gangrene. So if they're not getting enough blood flow, that tissue can die. They have kind of these punched out, well-defined borders. Often you can get tendon exposure. So in this picture, this white is all foot tendon that is showing. And they tend to be very painful, mostly painful because they're just not getting good blood flow. Um, Unfortunately, because the reason that they're having these ulcers is due to a blood flow issue, there's not anything that we're going to put on a wound that's going to magically make it heal. So the mainstay of the treatment is really trying to get some kind of blood flow back. So it's risk factor modification, so tobacco cessation, making sure that their blood pressure and their diabetes are controlled. Often they'll be treated with aspirin or Plavix to kind of thin their blood to help with any cholesterol issues or problems with blood flow in that way. Well, if they're overweight, weight loss would be helpful. But again, the treatment of the ulcer is really centered on vascular insufficiency. So trying to get them revascularization. Um, and so when they have any kind of a wound that actually has eschar on it, as opposed to any of the other ulcers we just talked about, that eschar is really protective because it's putting a protective coating on that ulcer that we're afraid isn't going to heal. And so from that perspective, it is good for keeping infection out. And so we're going to actually preserve that eschar and not take it off. And we usually do that with a drying agent. So either like skin prep, which is like an alcohol drying agent, or betadine to keep that eschar clean and dry and covered until possibly, hopefully, we can get some more blood flow to that area. And then venous stasis ulcers. So these are kind of the classical ulcers that people see with when you have someone who has leg edema and they get these real shallow ulcers. So because this is characterized by reflux, obstruction, or insufficiency of the calf muscle pump involving the superficial venous system, the deep venous system, or the veins. So their veins don't work well. They don't open and close all the way as they walk. And so they get extra fluid that gets stuck down in their legs. And these cause that fluid to seep out of their legs, causing ulcers. They often have this hyperpigmentation, so they'll get kind of a brownish tinting color of their legs. They will often have weeping because there's nowhere for that fluid to go. Again, most of the time they have edema, not always, but I mean, kind of classical, they usually do. And then these irregularly shaped shallow ulcers. They tend to be very, very moist because it's exudate. It's the exudate is moisture just purely coming out of the skin, and so fungal can be common, yeast because the skin is so moist. And the location commonly is this gator area, kind of from the ankles, kind of the mid calf. That's kind of the more predominant place. And so the mainstay of venous stasis ulcers is compression. So because they have this extra fluid and their venous system is not working correctly, you have to have some kind of external compression to keep that fluid out. Unfortunately, it's a lifelong issue and people don't like to wear compression lifelong. You might unfortunately get someone to wear it for a short period of time and then their legs get better and then they kind of get more lax with wearing them. And so then they reoccur. And so they reoccur a lot. And so compression therapy, again, is really important. We use a lot of alginate to kind of absorb the exudate that's coming out and foam dressings as well, kind of underneath the compression. And so what I tend to do for compression is I usually start with some kind of an ACE bandage or a Pro-4. A Pro-4 is this kind of 4-layered system that goes on that really kind of jump starts the compression. And once you get a majority of their edema out and you kind of get to a maintenance area, then you can switch to Job stockings or TED hose or something like that, depending on how much edema they have. Typically, someone that truly has venous stasis disease requires kind of the thicker Job stockings that are 40 milligrams of mercury pressure, as opposed to a TED hose, which tends to be more like 10 to 20. So it might not be enough at that level. So it just kind of depends individually on what's enough to keep that edema out. Again, this is a lifelong issue, and so it really needs to be lifelong compression. They make fancy stockings now with these zippers, and they have different pull devices that OT has to help with compression. So donning, because it can be kind of tedious to get them on. And then I just want to mention up here this part of it. So sometimes people that have venous stasis also have vascular. If you have vascular disease and you compress someone, it actually makes their vascular system worse. So there is some cases, especially someone who has vascular disease, where you really cannot adequately compress them as much as you would like. And we would know that by doing an ankle brachial index or a Doppler test on their legs. And so anyone who has an ABI that would be less than this 0.8 or more than 1.3, about half of them are not going to be able to tolerate compression. Or maybe they would tolerate a little bit lower compression. So it's kind of a trial and error in some instances. Again, lots of different dressing choices. I'm not going to go through those in much depth, but again, trying to pick those based on moisture. And again, one more time, just overall costs. So, companies like to put all sorts of things in their dressings to try to make them more costly. And I don't know that they really are much more helpful. So putting silver into things, silver is an antimicrobial. So, I mean, in theory, it could help with infection, but if you have something that's not infected, putting silver in it isn't going to help anything. And so, for example, if I'm choosing a gel out of all of these, I'm going to choose the hydrogel because I get twice as much for the lowest amount of price, and it's just as good as any of the other things that we're using. So just being kind of cost conscious. You will see in the nursing home and long-term care setting and skilled, especially with like knees and hips that have been done recently, you might see a negative pressure wound therapy vac. So just a couple of thoughts on them. They're mostly common, like I said, with joint replacements. Occasionally, we might use them on a pressure ulcer that has a lot of drainage. Their main thing is they're really good at drainage control. So again, first described in the 90s, it's kind of when they came out. And the idea behind them is that it's actually applying the subatmospheric pressure, and this is thought to reduce the inflammatory exudate debris, enhance circulation, and help with overall drainage. And so there are some contraindications. Anything that has osteo or malignancy or necrotic really shouldn't be using them. They are very expensive. You go back to the here down here. It costs about $2,300 for 10 dressing supplies. So again, trying to use them consciously. There's also some new kind of mini ones that have come out. Again, you'll see those kind of on your joints. And the idea is that they're already battery powered. And so they get stuck on the wound. And when the battery runs out, about 5 to 7 days, you can take them off. And they're nice because they're silent and they're small and they can be worn under clothes. So exciting that that's kind of where that's going for people so that they can hopefully enjoy more social activities if they need to. And these are my references. And I'd be happy to answer any questions if anyone wants to email me is great. And just to mention, this is kind of Dr. David Thomas, who taught me at SLU when I was going through NP school, and then I ended up doing wounds with him. And so he is my wound mentor. So thank you very much.